Good evening. Hope you are doing well and staying warm. I am Brother Dr. Jeffrey Sterling, Surgeon General for Alpha Phi Alpha Fraternity Incorporated. On behalf of our General President, Brother Willis Lonzo III, and our Board of Directors and the Deputy Surgeon General, I want to welcome you to this evening's webinar. You know, there's a specialty topic that we're engaging in like we don't typically do, but it's very important because we're talking about diabetes. And specifically, some of what we'll be discussing is diabetic retinopathy, which is a common eye disease that's actually the leading cause of blindness in working age adults. We'll get into the details of that, but the message is much as it usually is. You have a risk. We'll talk about those risks, but there are things that we want to empower you to do to forestall and prevent and minimize this, which is something that is very prevalent in diabetics, particularly those that have been diabetics for a long period of time and who have uncontrolled blood sugar, concomitant blood pressure, cholesterol levels, or smoke, or members of groups such as African Americans, Hispanics, and American Indians. We'll get into all of that. We welcome back as tonight's moderator, Alpha Phi Alpha's Deputy Surgeon General for Family Health. Brother Dr. Victor Narcisse III is a spring 1990 initiate of the Rho Iota chapter of Alpha Phi Alpha, and he's currently active in Alpha Eta Lambda chapter. He practices at the Houston Methodist Hospital as the Associate Division Head of Hospital Medicine, and he is the Director of Clinical Research in the Division of Hospital Medicine. Brother Dr. Narcisse is board certified in internal medicine and in geriatric medicine, and he is a fellow of the American College of Physicians and the Society of Hospital Medicine. Brother Dr. Narcisse, have a great show. Looking forward to the conversation.
Thanks so much. Again, we want to talk tonight about the complications of diabetes. Many members of my own family have diabetes. Many members of my community here in Houston have diabetes, and diabetes leads to blindness in too many of our patients. So we'd like to talk a little bit today about how that happens, why that seems to happen, and and most importantly, what can you do about it if you have diabetes. So I'd like to bring to the panel Brother Garvin H. Davis, MD, MPH, and Fellow of the American College of Physicians. He's from Baker, Louisiana originally, near Baton Rouge, not that far from my hometown in New Orleans. He's initiate of the Beta Iota Lambda chapter in 1993. He's currently working as a vitreoretinal surgeon at Houston Methodist Hospital here in Houston, Texas. He has his undergraduate degree from MIT in electrical engineering, a medical degree from Johns Hopkins School of Medicine. After an internship at Harvard Medical, he's done residency at the Willis Eye Hospital and then a retina fellowship at Baylor College of Medicine. That's where I first met him. He's his associate professor of medicine, and he is currently has had stations at MD Anderson and at UT School of Medicine. He is the Houston Medical Forum's 2003 Physician of the Year, and I have the honor to work alongside and occasionally to take care of patients with Dr. Davis. And I'm very grateful that he's able to take a few moments of his precious time to discuss diabetes and eye disease. Thank you so much.
Oh, thank you very much for having me, Brother Narcisse.
So I'd like to start with what seem to be the common kinds of problems that patients have with their eyes when they have diabetes.
Yeah, absolutely. So as the good doctor mentioned in the introduction, diabetes is one of the leading causes of blindness. And so I tell patients that diabetes is the leading cause of what we call preventable blindness. So of all the diseases that blind people, diabetes is the #1 disease that we can treat. That being said, you would think, hey, if we can treat it, then no big deal. It shouldn't be that prevalent. But it is. So even though we can treat it in the Western world, diabetes is the 3rd leading cause of blindness. How does it cause blindness? The primary way that we have trouble is with the retina, which is what I treat. I treat retinal diseases both surgically and medically. And the leading cause of the blindness in working age people is diabetic macular edema. So the retina swells and the vision decreases. Other ways that this can happen is we can get poor blood flow to the retina. blood vessels can break and bleed into the eye, blocking the view of the light. I always describe the eye like a camera. So light comes in, it gets focused by the front of the eye, and then it goes through the middle of the eye to the back, which is the retina, which is the film of the eye. So the majority of the issues are with the film of the eye. But in addition to that, diabetic patients are more likely to have advanced cataracts more quickly than others. So the lens that focuses the image onto the retina can become cloudy sooner rather than later. Now, everyone is going to get a cataract. It's like getting gray hair or losing your hair like myself, but it's something that happens to all of us as we get older. In diabetics, it happens sooner. In addition to that, you also at a higher risk for glaucoma. And so diabetic patients are twice as likely to have what we call open angle glaucoma. We can also get what we call neovascular glaucoma. And glaucoma, basically, the pressure in the eye goes up and it destroys the nerve of the eye. And that's very important in African Americans because glaucoma is underdiagnosed and undertreated in African Americans. And when we talk about overall, if we get off of diabetes for a second and say, okay, what are the 3 leading causes of blindness in general in all patients? Number 1 is age-related macular degeneration, which is a disease that doesn't affect African Americans quite as much as other populations. But then number 2 is glaucoma. And then number 3, as I mentioned, is diabetic retinopathy. So it's really important for us in particular to be aware of glaucoma and be aware of diabetes when it comes to preserving sight.
So these things seem to happen about 2 or 3 times more likely in African American patients. Do we have a sense of why that might be?
Well, like many things in the healthcare system, access to care is important, and we don't always have as much access. The disparities that affect medical care in general, in terms of, insurance, most of our insurance is tied to, to our jobs, and then the level of insurance can also be an issue in terms of getting access to some of the drugs that we have. Honestly, our health awareness and diet is, I'm sure we've had some talks on this show before about food being medicine. And unfortunately, some of the foods that we love aren't as healthy for us. So there's a big push to eat healthier and treat food like as a medicine, treat food like the medicine that it is. But yeah, there also may be a genetic component. In fact, we've one of the first studies that's ever been done to actually isolate the differences in patients that have different. So most clinical trials only have a very small population of diverse people. It's usually like 80 to 90% Caucasian, and then a sprinkling of some other races. One of the most recent eye studies done by one of our big drug companies actually made a big point of having a very diverse population where over 50 to 70% were African Americans or other people of color. And we noticed that some of the drugs work differently in us. We've seen that in hypertensive medications, and we're noticing it in some of our retina drugs as well.
What are the symptoms? If you have diabetes, what are the symptoms that you need to watch out for that might indicate you're having trouble with your eyes?
Yeah, so there are several things that, as I said, diabetes affects vision in several different ways. But typically, blurry vision, wavy vision. If you see floaters, all of a sudden see like floaters, or a lot of people will see blood in the eye if it's advanced. So in the vision, they'll all of a sudden see a big blob that looks red, or like someone sprinkled pepper in their vision. So floaters are pretty specific. Dark areas of vision, like if you look straight and say, okay, I have this area off to my right where I don't see anything, that can be a problem. But to be quite honest, diabetes sneaks up on you, similar to glaucoma. So it's better to let us find it than it is to wait for symptoms, because by the time the symptoms are there, honestly, sometimes the horse is out of the barn and we can't put it back. And so I encourage patients to really see their eye doctors very regularly so that we can find these diseases and these problems with the eye early.
We always worry about the folks who tell us about flashing lights or curtains over portions of their eyesight. Can you tell us what might be going on with those kinds of things?
Sure. Yeah. I'm a little out of the norm. Flashes are pretty non-specific to me. So the retina doesn't have any pain fibers. And so it responds to traction or pulling on it with flashes of light. And so, so yes, we're told about flashes, but flashes in isolation aren't as specific as floaters. So particularly so what's happening is something is pulling on the retina. And if that's the only thing that you see, like a flash every now and then I definitely say, walk to your ophthalmologist. You don't necessarily have to run. But if you see a shower of black spots or darkness in your vision, or it looks as though your visual field is coming down from one side, or there's a lot of blockage in the vision, then I'd say that's when I would run to my ophthalmologist instead of walking. So flashes are what we commonly say, but flashes isolated are pretty nonspecific and difficult to really say. And usually they will stop. What's usually happening is the gel of the eye is being pulled off the back of the eye, and the eye is responding by showing you flashes of light. And eventually, once that completely comes off, then the flashes will stop. There's another type of flash that you see on the side. People see shimmering lights on the side. Now, that's an ocular migraine. And again, that's something I would go in, walk, I would say within a week or so. I wouldn't go to the emergency room for that per se, but I would definitely want to see my ophthalmologist.
So what type of screening should you do? You said you want to find the problem before it becomes something you can't, that you would struggle to repair. What kinds of exams, how frequently do you need to do them? Would you recommend for people in general, and diabetics in particular?
So in general, after the age of 40, we recommend that you be seen yearly. With diabetes, it depends on the type. So with type 1 diabetes, usually type 1 diabetics are diagnosed early. So they're usually in their teens, 13, 14, 15. So those patients, we recommend being seen after 5 years of diagnosis, definitely being seen after 5 years, and then being seen yearly. Type 2 diabetics should be seen at diagnosis. I think that a lot of patients are coming to me now, and I ask them, well, how long have you been diabetic? And they're like, well, I've been pre-diabetic for 5 years, and then they finally called me diabetic, last year. And I asked them, okay, well, when did you start taking medicine? And they started taking medicine when they were quote unquote pre-diabetic. And so in my mind, that's when you've already started the process of having diabetes. And the longer you have diabetes, the more it affects the eye. After you've had diabetes for 20 years, there's an 80% chance that you'll have diabetic retinopathy in your eye. So that's when we initially start. So yearly eye exams. In addition to that, screening. If a diabetic becomes pregnant, they should be seen by an ophthalmologist, usually within the first trimester. And the reason is because if there's no retinopathy, then it can worsen with pregnancy. Like you can get retinopathy with pregnancy. But then if you already have retinopathy, it can worsen drastically with the pregnancy. So then after your diagnosis and you're examined, if we see nothing in the eye, we'll say come back in a year. If we see mild, then we'll say come back in 9 months. If we see moderate changes, and these are very specifically defined, we'll say come back in 6 months. And if we see what we call severe or proliferative diabetic retinopathy, then we'll be seeing you every 1 to 3 months.
Does it matter if you have a dilated exam, or if my my eye doctor always wants to take pictures of the back of the eye that
Mhm.
are not covered by insurance, and it's like a per cash charge for that kind of an exam. Do those make a difference?
I think they do. I think that when we compare looking at photos, and even actually with artificial intelligence nowadays, reading some of the images, but even if you're looking at an image versus looking at doing a dilated exam, a lot of times those images can show you a little bit more than you can see just by doing that exam, unless you're like a retina specialist like myself who looks at the retina every day. It's easy to, and even I can like miss one little small dot blot hemorrhage or microaneurysm. So I think these photos are helpful depending on who's looking at them. It's, and I think even ophthalmologists who aren't retina specialists, who don't always look at diabetic patients, um, you sometimes are better off. A lot of times you're better off in the hands of a retina specialist. It looks like I get referrals from my colleagues all the time where they say, "Oh, the patient doesn't have any diabetic retinopathy," and I look into the eye and I'm like, "This patient definitely has diabetic retinopathy." I think photos help with that. It depends on who's looking at it, though. If you're getting a photograph in your primary care doctor's office and it's not being reviewed by an ophthalmologist, then I would be concerned, because that person's only going to see the biggest problems and they're going to miss some of the subtleties. But in general, I like photographs. I photograph, and most retina specialists photograph a lot of patients, because it helps us see things that are easier to see with photograph than just with an exam.
You mentioned about the duration of diabetes as one of the risk factors. What we see on the internal medicine side of life is that the severity of the diabetes, essentially how well or how poorly controlled, seems to have an effect on so many things. Does that seem to have an effect on the diabetic retinopathy as well?
Oh, absolutely. Absolutely. So a couple of different ways. One, so controlling your blood sugar is very important. We have studies that show that you want to keep your hemoglobin A1C less than 7. I know that they're lowering that number in the internal medicine world, but in our world, below 7 is what we recommend from our studies. But in addition to controlling your blood sugar, you also have to control your blood pressure, because if your blood pressure is out of control, even with controlled blood sugar, you will still have problems with diabetic retinopathy.
Yeah.
But the higher number is absolutely worse. And on top of that, if your blood sugar goes above 200 at any point in time, you can get osmotic swelling of the lens. So you'll get blurry vision just without even affecting the retina, just with swelling of the lens. And so blood sugar control is extremely important when it comes to eye disease.
The general recommendations inside of internal medicine have changed from 7. Now we're trying to control people to 6.5, in some cases even lower. So we're spending a lot of time with that, and it seems that every point reduction of the hemoglobin A1C, and for those who might not know, the hemoglobin A1C is a 3-month average of indicator of how well or poorly controlled your blood sugars have been. So if you're well controlled, then your hemoglobin A1C would be lower, and if you're poorly controlled, your hemoglobin A1C would be higher. And again, below 7 is what we've classically aimed for, and now increasingly we're trying for 6.5. So the blood pressure, the blood sugar has been a thing. What about blood pressure?
Yeah, blood pressure is very important, to control the blood pressure as well. You can get an independent worsening of your diabetic retinopathy if you don't control your blood pressures. And so we recommend that as well. I challenge all my patients. I was like, look, I've seen so many patients blind from diabetes that if you control your blood sugar, you control your blood pressure, you can put me out of business. and at least for diabetic retinopathy. And I'm like, that's perfectly fine with me. I'll find something else to do. There's plenty of other retinal diseases compared to the feeling that I get when I have some young working age person walks in, not control their diabetes for 20 years, and they come in and that can't help them. And I have a couple of patients, that immediately come to mind that are exactly like that. So that, and I also recommend exercise and eating healthy, as we talked about, food as medicine. So, the DASH diet that people talk about, but also, I think everyone should really be concerned about what they eat. And I always remember, I'll never forget this. I was doing house calls as a medical student in the inner city of Baltimore. And we walked in and a lady was frying a hot dog and her pressure was through the roof. She was in a hypertensive crisis. So we said, all right, you must go to the emergency room. And, I was young and optimistic medical student. And I was like, I'm going to go and I'm going to stay with her until she's discharged from the hospital. So I followed her completely through that whole experience and sat with her, watching person after person come in with a stroke and saying, hey, look, this could be you if you don't control your blood pressure. And visited her the next week, and the message still didn't get through because she was still now eating, fried pork rinds. And so food is just so important. I think and this was obviously like 30 years ago. So hopefully people are getting the message a little bit more with eating, but it is so important to diabetic control.
This has been pervasive, and I'm also from Louisiana, and the types of food that make New Orleans and Southeast Louisiana famous are foods that are essentially high in sodium, high in cholesterol and fats, high in caloric intake, and it's increasingly difficult. I have made lots of adjustments to my own nutritional intake. I will never say that I'm on a diet, but I still gravitate to these foods that I grew up with that are really, in a generational way, unhealthy.
Absolutely. I mean, it's good food. I always tell people, when I grew up in Louisiana, then went to school in Boston, I was like, why are you guys eating cardboard? I mean, Louisiana eating is a hobby. Like, we take it seriously, but we have to find ways to make it healthier for us.
One of the questions that came in about the monitoring of the hemoglobin A1C, if you're a diabetic patient, then your doctor will give you a schedule of how often your hemoglobin A1C needs to be checked. Usually it's at least once a year, but you should be checking your blood sugar very frequently. And depending on the type of diabetes and how poorly or well controlled it is, it might be, I have some patients where I advocate that they check their blood sugar with the finger stick 4 times a day. If they don't like to do that, increasingly there are continuous glucose monitors that you'll see people wear on their arm or on their occasionally on their tummies, that will check their blood sugars all the time and give averages to your smartphone. And that's really useful advances, but some of those are pricier. But your doctor probably should be the one that will go over how frequently. You should definitely be engaging your primary care doctor on an annual basis for sure. And many patients with diabetes really need to see their primary care doctors twice a year or 4 times a year. That's a very common thing.
Yeah, that's great, Victoria. I love the continuous glucose monitors. I mean, because I think in addition to telling you where you are, it'll help you with your eating. And now everyone doesn't qualify for them from an insurance point of view, but you'll know that, okay, well, if I eat this, my blood sugar goes up immediately, and then you kind of stop eating that. And I think that type of immediate feedback is so critical to managing this difficult disease. Now, that's one thing I do want to say is that, diabetes is a tough disease, and it's hard to keep all the balls in the air when you have to see your endocrinologist, your medical doctor, and your eye doctor, and your podiatrist, and maybe your kidney doctor. The key to all of that is just controlling the blood sugar. And I would say, again, I know we're here talking about eye disease, and I think, that's don't neglect the eye doctor. Don't think that just because you're not seeing anything or having any symptoms, your eyes are fine, because I can tell you that they may not be, and by the time they're not fine, they may not be repairable.
So we talk a lot about nutrition, cholesterol. Cholesterol doesn't seem to have as large an impact as the diabetes and the blood sugars and the blood pressures seem to, but I'm still a large advocate for diabetics lowering their cholesterol because of the cardiovascular disease implications. So that's stroke, which in the wrong place could affect your vision, heart attacks, poor blood flow to your legs that lead to amputation, poor blood flow that leads to your kidneys needing dialysis support at sometimes. So that's an important part of diabetes. It's not quite as doesn't seem to be quite as specific for retinopathy.
No, we haven't found a correlation with that at all. I mean, it's been studied and looked at. Again, with blood thinners, we haven't noticed anything with those at all. We looked at aspirin to see whether aspirin would help. We haven't seen any results or any benefit to that at all. Mostly blood sugar and blood pressure. Those are the keys for us.
Well, one of the things that I have done throughout this series is I've tried to change my activity level. I cycle more. I went cycling today for an hour and a half. But still, what I've been so disappointed to learn firsthand, even though I think I learned it a long time ago in medical school, is that you can't out exercise a poor diet, a poor nutritional plan. And you spend an hour on a bike, and it's 350 calories spent, 400 calories spent, something along that line. You said, well, gosh, how much is that compared to a can of Coke? How much is that compared to a bag of chips? And I can easily overwhelm everything that I gained by doing lots of physical exertion if I'm not eating well. So I really think that those two things have to go together, and it's really important. What about sleep apnea? We're seeing more patients as our collective weights seem to increase. More people seem to have sleep apnea. Does that seem to have an effect in retinopathy?
Yeah, we do think that sleep apnea can affect the blood flow to the eye. We're seeing that a couple of things, actually. One is that some studies have shown that sleep apnea can lead to worsening of your diabetic retinopathy, but also we found an independent correlation with looking at the vasculature. So the vessels in the eye are fairly smooth. You can, in terms of their course, you get to give it as kind of a straight, slightly winding road. But we found that even with sleep apnea, sometimes we see that this kind of curving road becomes more like multiple S curves that can affect the vessels that are in the retina. So absolutely, you want to, again, losing weight helps with sleep apnea in general, but also they're treating the sleep apnea and getting the oxygen to the tissues in the brain and eye are important.
So I think there's unanimity that prevention is better than treatment. I know that sometimes, and in fact, you and I share a young patient, 33 years old, that is starting to have eye symptoms a few days ago in the hospital. What kinds of treatment options do you have available if a person does have retinopathy?
Yeah, so if you have retinopathy, the early stages, we watch and encourage the things that we talked about already. Weight loss, blood sugar control, blood pressure control, etc. But once it starts to affect your eye, then we have a couple of different ways to treat. There's a chemical in the body that we call vascular endothelial growth factor. And in diabetics and some other diseases, the level of vascular endothelial growth factor increases in the retina and in the eye. And so one of our mainstays of treatment is injecting a medicine that we call an anti-vascular endothelial growth factor medicine. So it's an antibody to this chemical that is produced by the body due to hypoxia. Basically, if the retina is not getting hypoxia being low oxygen. So what happens is the small vessels in the retina get shut down with diabetes, and then the retinal tissue sends out this help signal. Help, give me, and that's the vascular growth factor. And then our medicines that we actually inject into the eye remove that chemical from the body. That's one way that we treat. And a lot of people ask, well, how are these injections? And we can talk a little bit more about those. They're excellent. It's a true example of 0 to 1. When I was training, doing my fellowship in 2002 to 2004, we weren't injecting in the eye almost at all. If we were injecting steroids. The first medicine was approved in 2004, and now ocular injections are the #1 procedure in all of medicine because of the prevalence of the diseases that we talked about and how like the injections, the anti-VEGFs help in more than just one disease, and diabetes is one of the biggest ones. The other thing that we can do is some patients require a different anti-inflammatory pathway. So we'll inject steroid in the eye, similar to the steroid that you'll put in a knee that hurts or something, and that decreases one of the pathways of inflammation in the eye, and that can help with swelling. In the old days, and we still do it some, what we would do is take a laser and laser the tissue that was swollen for diabetic retinopathy. There were several theories as to why that works and why that still works, but we only do it now in patients where the swelling is not in the very center part of the vision. If it's in the very center part of the vision, we almost always inject. And then finally, and these are talking mostly about swelling in the retina, since that's the most common cause for working age people. But then when the disease starts to progress, so I mentioned earlier, we go from mild, moderate to severe, what we call non-proliferative. So that means the eye isn't, quote unquote, like there are no new blood vessels there to break and are bleeding, but we're seeing signs in the eye that the eye is suffering. But usually those signs don't lead to decreased vision unless we get the swelling in the macula. So then the final stage is what we call proliferative diabetic retinopathy, and that's a very dangerous one. That's when you have new blood vessels that grow. Those blood vessels can break and lead to bleeding in the eye. They can also lead to fibrosis and scar tissue that pulls the retina off of the back of the eye. And we also can get very ischemic retinas where you don't have blood flow anymore. And that's a dangerous position that we try to prevent. In those cases, we will use the laser to destroy retinal tissue because the tissue that you don't need as much, we destroy with the laser in order to preserve the center part of the vision that you do need, or the center part of the retina that provides the majority of the vision, the one that you do need. And then sometimes even with that, you have blood in the eye, and the blood sometimes will absorb, but other times we have to surgically go into the eye, remove the blood from the eye, remove the scar tissue, and then additionally add laser. And sometimes we have to hold the retina in place because it's being dragged off the back of the eye. And that's also a very dangerous position to be in. A lot of times we can help people, sometimes we can't.
Well, it sounds like the thing that individuals need to do most is control your diabetes well. That's working with your primary care doctor. Control your blood pressure well. Again, working with your primary care team. But in terms of your vision and the vision team, it still seems like only about half patients with diabetes actually get their annual dilated screening exams. It seems that if we should just continue to spend more time, energy, and effort getting those things done. So I like your idea about exercise and nutrition. I love the idea of better control of diabetes and high blood pressure. I love your idea of increasing mobility and exercise. And some of the things that we talk about in terms of a mnemonic is stay on track. Take your medicines as described by your doctor, reach and maintain your healthy weight, add physical activity to your daily routine, control your hemoglobin A1C, control your ABCs, hemoglobin A1C, your B blood pressure, and your C cholesterol. Okay, fair enough. Cholesterol is not the best here, and then the last is avoiding smoking. Tobacco use still does seem to have negative effects on diabetes and likely on vision as well.
Absolutely. Yeah, no, I agree with those. Those are absolutely things that we should be doing. And I agree with you. I mean, even if cholesterol won't improve your retinopathy, I would venture to say that almost every cardiologist on the planet wants their cholesterol low, and some take medicines just to keep it low because, I always say the heart and brain trump the eye. So if your heart's not working, then it doesn't really matter how good your heart's doing. So, I'm sorry, if your heart's not working, it doesn't really matter how well your eye is doing, because I need your heart to pump blood to the eye, and I need your brain to interpret the signal that's coming from the eye. So those are
take your medicines, reach your healthy weight, add physical activity, control your A1C, diabetes, B blood pressure, C cholesterol, kick the smoking habit. Those are some great ideas, and I'm so appreciative of brother Dr. Davis for taking so much of his time. I know he's on call today, so I need to get him away to get back to work. Final comments from you, Brother Davis?
No, thank you, Brother Dr. Narcisse, for doing your good duty and helping our brothers and our colleagues and our families and our community really be made aware of these things that are so important. A little bit of knowledge goes a long way, and hopefully this is spreading great information that will help us all. We need to be our brother's keeper, and I appreciate what you're doing to make sure that that's happening.
I did see a question in the chat about nutrition, whether you have prostate cancer or not. Again, the diet, not the one that I grew up with, is high in fried foods and high in sodium, but nutrition that avoids processed foods. We've had many conversations about whether a plant-based diet is a better way to go, but the clarity for the questions in the chat around diet in prostate cancer and in diabetes and in high blood pressure is all about reducing the amount of processed foods, processed fats, and I think that those things are very, very important. The recording is available on the Sphinx TV YouTube website. You can also find it on the Alpha Phi Alpha chat in Facebook. If you have questions, please remember to join us tomorrow. The General President election announcements will be provided on those channels, 7 p.m. Eastern, 6 p.m. Central. We'll continue to do our Surgeon General Initiative presentations on several times a month. Please look out for our next presentation. And I'm going to give everyone their evening back. Thank you so much for taking the interest in your health and in your body and in your life. Eat well, behave well, get your medicines, work with your doctors. Keep from getting these problems. If you do, work with your physicians, and they will continue to help you. We wish you a great evening from Alpha Phi Alpha Fraternity Incorporated. We'd like to thank our current General President, William Lonzer, who has supported this initiative. And you heard earlier from our Surgeon General, Brother Dr. Jeffrey Sterling. We thank both of them for their ongoing support. Have a good evening.
Good evening. Take care, brothers.